This better? Great. Okay, well, while Jill is getting us started, I can at least kind of introduce this session. So AI is reshaping health, and we've just seen some examples of that, and healthcare by transforming how we diagnose disease, develop treatments, and deliver care. These systems can analyze large and complex health data, such as medical images, electronic health records, and genomic information to support earlier diagnosis, more personalized treatment decisions, and more efficient healthcare operations. Beyond individual patient care, AI also has the potential to improve population health by identifying patterns across large data sets and informing public health strategies. At the same time, integrating AI into real-world healthcare systems raises important questions about transparency, trust, and equity, particularly when algorithms are trained on data that may reflect discriminatory ideologies or existing disparities in care. The challenge for the field then is not only to build powerful models, but to ensure they're implemented responsibly and benefit all patients. So today's discussion is going to focus on equity and artificial intelligence. And it's my pleasure to introduce Dr. Ned Carney. He is the Irene and Dr. Arthur M. Fishberg Professor of Medicine at the Icahn School of Medicine at Mount Sinai. He's an expert physician scientist, bridging the gap between comprehensive clinical care and innovative research. He's the system chief of the Division of Data-Driven and Digital Medicine, the co-director of the Mount Sinai Clinical Intelligence Center, and the director of the Charles Bronfman, I apologize, I know I just butchered that, Institute for Personalized Care. He's authored more than 240 peer-reviewed scientific publications, including articles in the New England Journal of Medicine, the Journal of the American Medical Association, the Annals of Internal Medicine, and Nature Medicine. He's the principal or co-investigator for several grants funded by the National Institutes of Health, focusing on informatics, data science, and precision medicine. He's also one of the multiple principal investigators of the NIH Recover Consortium, focusing on the long-term sequelae of COVID-19. He has several patents and is the scientific co-founder of investor-backed companies, one of which is listed in NASDAQ. So welcome, Dr. Ned Carney. It's a pleasure to have you here with us today.
Thank you so much for having me, and I'm sorry I couldn't be there in person. I have a 6-year-old and a 1-year-old, and they don't go to sleep unless I'm there.
Oh, that sounds awful. Sorry. So do you want to maybe start with giving us a bit of an overview of your work? And then I've got some questions for you.
Absolutely. Again, it's a pleasure and honor to be here. I mostly work at the intersection of computers and humans, and by that I mean that I think about how this algorithms are applied to clinical care, sort of in clinical implementation, but at the same time making sure that they are safe, effective, ethical, and equitable to all. So I've done work that has informed policy on sort of the fairness aspect of these algorithms, as well as I've done work that has informed policy on like how do you govern and how do you monitor these algorithms. So I have sort of two roles, right? I have a educational role and an academic role as my role in the School of Medicine, but then I also have a role, thanks to our leadership in the health system, where I'm responsible for thinking about governance and implementation and adoption, and how do we make sure that this benefit everyone, not just someone, and more importantly, don't harm groups of people.
Fabulous. So to start broadly, as a leader in the field, how do you think about institutionalizing equity within AI strategies? Is it primarily a technical problem, a governance issue, or ultimately a leadership responsibility, or all three?
Well, I think it's primarily a leadership responsibility because um, as healthcare in general, and as clinicians, and broadly the healthcare delivery system, our primary responsibility is to do no harm. And it's not do no harm to certain groups of people, it's to do no harm to everyone. So it's primarily a leadership responsibility. And if it becomes a leadership responsibility at the strategic as well as the executive level, that translates into how you do it, right? How you do it is there's various ways. There's infrastructure, there's governance, there's monitoring, there's execution, there's implementation and adoption, right? But if we recognize it as a leadership and an executive responsibility, and more, I mean, I'll take it one step further, right? If we recognize it as one of our values and one of our missions, then that sort of percolates down into how you do it. But this impetus has to come from like the leadership, where the primary responsibility is, you know, um, uh, implementing this algorithms or implementing this technology, right? They're more than algorithms at this point of time, in a safe, effective, ethical, and responsible manner. And then it becomes how to do it, right? And there are ways to do it on a governance level, right? Making sure that before anything touches patients or providers, there's no bias in it, it performs adequately in different subgroups. It becomes an infrastructure question because as algorithms change over time, to how do you monitor them by stress testing and red teaming, et cetera, et cetera. And it also becomes an execution responsibility. And by that, I mean that you can have you can check bias at the data level, you can check bias at the algorithm level. But even if you have a perfectly unbiased algorithm, there can still be injustice in its application. Like, I'll give you an example, right? Uh, you know, uh, Suppose you had I mean, this is an actual case that happened. You had an algorithm for predicting which patients are likely not to show up for an appointment, right? And that is sort of intrinsically tied with social factors, right? The reason that you can't get to an appointment sometimes is because you can't get a day off work, especially if you are in a low, a hourly job without health insurance, or you live like really far away from the hospital. If you live in a rural area or an urban desert and you can't get transportation, or you don't have anyone to watch your kids when you need to go get to a doctor, right? And then the algorithm is not biased because it tells you that certain groups of disadvantaged people are at higher risk of not having of no showing for not showing up for that appointment. So you have a completely unbiased algorithm because its performance is appropriate in those groups of people, and you've highlighted the risk there. But then you can have injustice in its application because you have two choices here, right? One is, for those group of people, you cancel the appointments and you rebook for someone else, and that's an injustice because you've sort of perpetuated disparities. Or you find them ways to get to that appointment, right? You give them a doctor's note, or you find transportation, or you have a place where the kids can come while they're having a doctor's appointment. That actually what happened in Mount Sinai is that you had this algorithm which was unbiased, as it were, in terms of uh, 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 identifying accurately which group of people. And as you can tell, this was people from like disproportionately disadvantaged backgrounds, historically underprivileged backgrounds. But then, we had a choice. Do you cancel this appointment and you rebook them for someone else, or you proactively reach out to these people using our social work colleagues and like find them ways of getting to that appointment? And we did the latter. So I think that um, if we just think of this as a technical issue or an infrastructure issue, or a governance issue on the AI front, and not think about the downstream applications and executions, then you're sort of solving only half of the problem, or even less than half of the problem, because the execution is where the rubber meets the roads. And that is where I think for the latter part of the execution, it becomes much more focused on communities. It's much more focused on a multidisciplinary approach in order to not perpetuate biases in execution for even a completely unbiased algorithm. Does that resonate?
Yes. Thank you. And thank you for the example. That
I can't hear you.
you hear me?
Now I can.
Okay, sorry about that. How do you define and measure equitable performance in a clinical AI model?
Okay, so this is a complicated question, and this is a complicated question because AI now has taken several forms, right? And and it if we don't know how to define something, we can't really talk about it efficiently and accurately. Like if we just said, if we had only one word for a plane, a bicycle, a car, a rocket ship, a unicycle, and we just called them vehicle, we wouldn't really know what we are talking about, right? So this is a very simplistic thing, but it'll suffice. We can define clinical AI into two broad categories. One is predictive, where it tells you what is going to happen to a patient or a group of patients. And the second is generative, which are chatbots. In some senses of the word, predictive AI is easy to debias as compared to generative AI, because predictive AI, you put in one set of inputs, you get one set of outputs repeatedly. It's very deterministic because something goes in, something comes out, and you can sort of know what comes out as long as you know the inputs, right? Generative AI is much more difficult because depending upon the time of the day, even you put in the same exact set of inputs. And I'm sure you've seen this, right? You give it the exact same question today and tomorrow, and it gives up you very quite different answers. So that's very hard to say it's deterministic, because you can give it the exact same set of inputs and it gives you a very different set of outputs. So predictive AI is, you know how to debias it, right? First, you start off with a
Mm.
diverse data set, making sure that there's a representation from various groups. Uh, Data is collected adequately, so there's no shortcuts that the model can take, like, for example, zip code for identifying racial race or income. Then you pick the correct outcome, right? Because there are outcomes that you can pick that would disadvantage certain groups of people. Simple example is, if you want to like look for which patients are sick, you should pick at how many conditions that they have, not how much they spend on treatment. Because if you pick something that you spend on treatment, obviously people who are economically disadvantaged spend less on treatment because they have less money, and then that will lead you to a bias where you see that it's uh, 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 and then you basically make sure that the predictive performance is the same in all of the demographic groups, whichever ones you choose, then that can be different based upon the use case. And then, if you have appropriate, and I'm not saying equal, but appropriate performance in the group, and then you go on to the execution phase, which makes it appropriate execution, even if you know it's a completely unbiased algorithm, like I pointed out earlier. You can have problems with the execution. Generative AI, in my opinion, are a completely different kettle of fish, right? We had a paper which last year which showed that depending upon, if you just changed one demographic detail in the model, you changed a white person to a black person, man to a woman, uh, stable housing to unhoused, it completely changes its clinical recommendations beyond what is clinically justified. So generative AI has to have almost like, and I don't have the answers here because this is a evolving field. I can just tell you what I think. Before these algorithms get released, they have to undergo rigorous stress testing, almost by changing the parameters around clinical cases. So at least you know what it is. And then some of it is an architectural issue where you basically put in the model that do not discriminate between black or white, or do not discriminate between man or woman, et cetera, beyond what is clinically justifiable. But then this had to be monitored at regular intervals to make sure that like the bias doesn't perpetuate, and there's no bias. And then for decisions that actually have critical impact, and not just medical impact, but like access impact, or like which patient should see a doctor, or social impact, like which patient should get a social worker. Those have to be sort of escalated to a human, who's with, because there's accountability there. And like and then in a certain group of decisions, they have to be monitored independently by community members to make sure that they align with like the values that we are trying to do this. A lot of this is infrastructural, where you can have uh, uh, you know, uh, almost like real-time monitoring. But right now, what I worry, and I'm sorry, I'm digressing a little bit. What I worry is like everyone's in the race to deploy more and more and more, while safety and equity are not at the forefront. They're just like, can we deploy more and more? Can we put more and more into production? And I think that's the right, wrong way, because I think if you anchor this on safety and equity, then adoption increases because, ultimately healthcare and relationships, right? Healthcare is a relationship at the end of it, is a matter of trust. And if trust is broken, then it's very hard to regain it with the community.
Thank you so much. So it sounds like constant monitoring is probably the key, right? At least right now. And equity starts actually with the data, right? So your research has emphasized large scale clinical data and machine learning in real world hospital systems. How do you ensure that the data sets used to train these models adequately represent historically marginalized populations?
Yeah. So I think one is you have to start off with diverse data sets, right? You have to start off with data sets that represent the population in which you're trying to make a clinical or a operational decision. Because, for example, um, if you if you have a data set from Idaho and you train a model on that, it's very unlikely that it's going to be working on a place like New York City, which is one of the most diverse places in the world. So you have to start off with a diverse data set. But I think it's a misconception that it ends there, right? Because diversity of data set is one metric of fairness. The second metric of fairness is which outcome you pick for this particular model. Like the example I gave earlier, right? If you want a proxy for how many comorbidities the patient has, which is an important predictor of anything and everything, right? If you pick uh, 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 total number of conditions, you'll probably be fine. But if you pick something like healthcare spending, that is going to be a much more biased outcome. And that actually happened at scale. I don't know if you know this paper. Ziad Obermeyer, who's one of the giants in this field, he published a paper around 5 years back at this point of time. So what basically happened was there was this large insurance company that was trying to figure out sort of how to give benefits to their covered lives. And instead of picking how sick people were by how many diseases or how many conditions they have, they picked healthcare spending. And as a result of that, that automatically deprioritize Black individuals and lower income individuals for getting more healthcare benefits. So that was an example of if you pick the wrong outcome, you can have bias at scale, right? And uh, one more point that I sort of want to make is that uh, 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 you know bias is bad, right? And bias exists in humans, right? Let's just be clear and honest about, clear-eyed about it, right? There are some humans which are biased. There are some doctors which are biased. There are other clinicians which are biased. There are other healthcare providers which are biased. But those affect. That's a matter of scale, right? If there's a biased doctor, he or she might be treating 10, 20, 30 patients, and those probably are it's bad. But if you have a systematic bias in an algorithm at this, for example, affected 50 million people. So, that's the promise is scale because you can scale knowledge and you can scale expertise. But the flip side of that is that there's a systematic bias or a systematic error that also affects millions of people, right? So, and it can run away very, very quickly before you can catch it. That's why, thinking about this before you deploy stuff is sort of critical.
Absolutely. Um, so, relatedly, um, do you believe clinical AI should incorporate community level data, such as
Absolutely.
housing instability, environmental exposure, etc.? And if so, how can that information be integrated ethically?
I think it absolutely should do it, which we are not doing right now, and that's a big missing gap in the field. Because if you don't do it, and the models tend to take shortcuts in order to impute those things from other things, and that introduces bias at scale, which is very hard to resolve just because of the black box nature of some of these models, right? I think the way we should be doing this is talking to communities and asking them what is the most important thing to include in these models, right? And what is the most important thing on the top of their mind that can represent the needs of that community without introducing bias that can further deprioritize or affect care. We've started doing this a little bit, not at the scale I would like to be honest, but we started doing this a little bit thanks to one of my mentors, Carol Horowitz, who's the head of community engagement at Mount Sinai, where we have convened a community advisory board around AI to tell them to ask them what's most important to us. But I think that like there are modern computational techniques that you can use to get this information without asking, without too much effort, which basically involves geocoding and geomapping, even at the community block level, and like correlating with other sources of information like food deserts and availability of public transport and availability of walkable spaces and availability of green spaces. But it's not being done right now, and I think that's a big missing gap in this field, because right now uh, we are introducing unseen bias at a scale that could affect many lives. I think community involvement needs to be central, and then once you decide how do you integrate this ethically, which needs a decision that needs to be made in collaboration with community, then you can do it with computational method. The bottleneck is not a technology here. I can assure you that.
Thank you. It does seem that including that information would help potentially reduce some bias because the algorithm would be able to take those variables into consideration when spitting out the output, right? Um,
Absolutely.
and I would say, I think I really love the idea of community engaged AI. I'm all about community engaged research. And I think that is embedding the community voice in any way that you can is so critically important. So I really love that. And as these models move toward clinical use, should fairness auditing be mandatory before deployment? And if so, what should a meaningful auditing process look like?
I think fairness auditing should be absolutely mandatory and required by policy and regulation before deployment. And for that, again, going back to my earlier point, it should depend upon the uh, what kind of AI it is, predictive versus generative, what you're thinking about using it for. So you select the right outcome and you make sure that the performance is appropriate. Doesn't have to be equal. Performance is appropriate in particular subgroups, right? It can't be equal because the risk of some things are much higher in certain communities than others. So if you force it to be equal, you're actually introducing another kind of bias, right? It needs to be appropriate in each subgroup, and then execution needs to be this. Right now, fairness auditing uh, is not mandated, and it should be mandated at the institutional level and maybe by policy at the state or federal level. But it's not right now. It's very optional to do. I think it should be included as a quality metric, right? Because I think if more and more operational and clinical decisions get are not outsourced, are augmented by AI. We do that for other things that we do clinical decisions on, right? Like, laboratories have to undergo strict quality standards. ORs have to undergo strict quality standards. Even things like, infection rates, hand washing have to undergo good quality standards. If you are using this to make drugs have to undergo quality standards, right? If you are using this and to influence or make clinical decisions, why shouldn't it be something different?
I couldn't agree more. I think it is incredibly important that we have some sort of monitoring. Whether I actually would advocate for policy level, so it shouldn't be an option. Um, there's often a gap between publishing a model and actually implementing it in practice. From your experience, where do equity concerns most commonly emerge during the development of the model, its validation, or in its deployment?
All three places. But I think equity concerns even emerge one place before that. The reasons that a lot of models are not deployed into clinical care, I mean, not that all models should be deployed into clinical care, because then that is a different story altogether, is that the reason that a lot of models are not deployed into clinical care is like, um, no one asked for it, right? You haven't talked to patients, you haven't talked to clinicians, you haven't talked to communities to figure out what their pain points are. And if you do that in a vacuum and you develop a model in a vacuum and no one asked for it, it's by definition not going to be useful to many people. And as a result of that, it won't get this. But equity concerns can occur at all stages of the model development process, right? From the data to the development to the validation to the execution. And the worst part is it's almost not a straight line because it's almost like a circle. Because if you develop a model on biased data and then you validate it using biased outcomes, and then you implement it in biased ways, that actually feeds in to create more biased data, which sort of perpetuates this unvirtuous cycle from hell.
Um, you gave us one example, but have you seen other cases where a technically strong model produced unintended inequitable outcomes once it was integrated into care workflows?
Yeah, I mean, I can give you the no-show example was a good one. We caught it early. The other one was the one that I talked about briefly with Ziad's work doing remote patient monitoring outcomes. The third one is a there was a large sepsis model that was deployed at many institutions across the country. One of my colleagues, Karandeep, found that it performed really badly overall. It performed much worse in certain subgroups, and we deployed that without doing fairness checks and fairness audits on it. The I'll give you an example of my work, which is a little concerning, and it goes away from health systems for a little bit. So some of you might know ChatGPT Health introduced their consumer AI facing product called ChatGPT Health in January. It was big because it's first time, and these models, to be fair, operate in a regulatorily gray zone because they are supposed to give you health guidance or health advice without giving you clinical decisions, right? But like people are going to use them for clinical decisions, right? You give them a symptoms, and next step is like, what should I do next, right? That's just human nature about how we use models. And we had this manuscript published last week, which showed that uh, uh, it massively under triaged. That when you have an emergency, and you triage it, you're supposed to go to an emergency room, right? But ChatGPT has massively under triaged emergencies, like you're having diabetic ketoacidosis, they told you to stay at home, right? And we did a fairness audit on that. We didn't have the sample size to do it because you had to feed in one case at a time, but it showed that it did it worse in like women versus men, black versus this. So that's a thing happening actively at scale where like 40 million people are using it, and we don't know basic safety facts about it.
That's very troubling. Oh my goodness. So stepping back to the patient side of the equation, what level of transparency should patients have when AI tools are influencing decisions about their care?
So sort of answering that question in two ways, right? The way AI tools influence care is in two broad areas, right? One is within the umbrella of their healthcare organization, and the second one is when they go directly to a chat GPT or a Gemini or a Claude and ask it health questions, right? The first one, I think that healthcare organizations have a lot more influence over. So they should, patients should be informed whenever AI is being used in their health. And sometimes it's useful to use AI in health for like routine tasks or second opinion or something. The patient should be informed about that a priori. And we do that as a form of a patient-facing disclosure in plain language anytime a patient comes to the hospital, to the website, et cetera, et cetera. The second one is a little more complicated because they are under these direct to patient tools, for lack of a better word, consumer facing AI, are under no obligations to tell patients anything. They under the disclaimer that they are under the disclaimer about you know we are providing health guidance and health advice, not clinical decision support, but that's not how people use them for, right? So I think a lot of work needs to be done in that aspect. And that is going to be a policy regulation question. And to be honest, what's happening right now, with the conflict between federal regulation or the lack thereof of it and state level regulation, I don't know what's going to happen, to be honest. I don't think anyone does, because this is going to be fought out in courts, right? Because as you know, the federal government imposed a moratorium on any AI policy, including health. States can't do their own policy, but states have already passed their own AI policies and laws with the New York RAISE Act and California Act, which is similar, which demands transparency from this. So I don't know how that's going to play out, but that has to be a policy sort of regulation fix. I'll actually take that back. And the third thing that the patients need to be aware of is, you know, things that influence their healthcare experience and journey, not necessarily clinical, right? Things like, you know, a lot of payers are using AI to deny claims, right? For uh,
I'm sorry, can you repeat that? They're using AI for what?
a lot of payers, like insurance companies, are using AI to deny claims from hospitals, right? And there is a lack of transparency there around why they are being used to deny claims. Uh, that affects health broadly, because if your bills start racking up, your healthcare bills start racking up, that makes you much less likely to seek healthcare, and then you get worse and worse and land up in the emergency room, right? So there needs to be some transparency, or a lot of transparency there, about what AI they are using, what they are using to deny claims, is it biased or not? Because this has already happened in the pre-generative AI era, where payers used AI predictive models to figure out benefits and to deny claims, and it's going to be this. And I think that, like, uh, this is especially important to have transparency at all of these levels, particularly because, and I pray and hope it'll change, but there's already a distrust of the healthcare and medical system at large. I mean, you see with what's happening with the vaccinations, et cetera, et cetera. And, this has the potential to actually worsen that significantly. And I think, starting with our own healthcare institutions, we need to, like, make a change, but also make our voice heard together for policy at the state and the central level around consumer facing, but also like payer facing AI.
Thank you. And we have comments coming in. Transparency is absolutely vital. And if we need what trust there exists um, between the community and our institutions really needs to be fostered and not impeded and diminished. So I think that policy is definitely going to be needed, robust policy. And thinking about the future workforce, what skills should the next generation of clinicians, researchers, and even communities develop to critically evaluate AI through an equity lens?
So this is something I don't have a complete answer to, because it's evolving. I'll just start out with that. What I think is going to be most important is is which is also the most thing that we are losing right now, is critical thinking and judgment. I think, and that's where we are to draw from older disciplines like philosophy and critical thinking and the social sciences, because, the way I envision this is like, fine, the error rate of AI is like 2%, but you don't know which 2%, right? If you knew which 2%, like if you had a thing that failed predictably the same time every day, you could guard and mitigate around it. And that doesn't require much critical thinking. You just put a process in place and you're done, right? But you don't know if it's going to fail today, tomorrow, a year from now, when it's going to fail, in what context, right? So I think that, like, critical thinking is going to be key, and because the systems hallucinate, they omit information, etc., etc. So as a result of that, I believe that critical thinking and communication are the two most key aspects. But also, like, how do you rebuild trust is a key aspect of these things, because I think trust is in short supply now, but it's a currency of healthcare. And I think, how do you make people trust you? How do you make people this, especially in the edge of like era of like AI-induced misinformation, and and I don't know. I honestly don't know how to do that.
Thank, thank you for that. It does seem that critical thinking is going to be very important, but we all, I think, on a just general level, everyone needs to have a basic foundational knowledge of AI in order to be able to critically evaluate whether it's spitting out something that is correct or potentially has bias, right? So I think we all need to educate ourselves on AI and its use and potential risks. Finally, when you look ahead 5 years, what do you think will separate health systems that successfully used AI to reduce disparities and inequities from those that inadvertently widened them?
I think like health systems currency ultimately is trust. So people that, ultimately things come out, right? Sunlight is the best disinfectant. So if health systems used AI to like worsen disparities, that's going to come out at some point of time. And not just health systems, like companies, AI providers, payers, etc., etc. So I do think that like we just need to be fearless in calling out these things when they come, and like as a result, health systems, etc., will be you know it will be advantageous to center AI around equity, fairness, and transparency rather than not. But there also needs to be a strident voice coming from all of us as people who care about patients and more importantly care about our communities at large, to make those changes in terms of policy and regulations, right? Because that's one way to almost codify safety and fairness into practice. And there have been some things around that, particularly with the New York Race Act, which demands transparency from AI, etc., but not enough. So I think we just need to like accelerate that work. And I think communities and people like yourself have a very strong voice to play in that, because it's absolutely necessary that people who are developing, deploying, implementing AI hear that voice, and regulators and policymakers hear that voice.
Thank you so much. It does seem from our discussion that the scale of the problem with AI, the bias problem with AI is just the potential to exponentially create a lot of issues, right? So I believe from our conversation, even more so now, that true policy needs to be in place in order to put some guardrails around how it's used, what data is fed into it, how it's interpreted, et cetera, right? So thank you so much for this conversation, for being here
Again,
today. I'm going to open the floor to questions.
Does anybody have a question for either Dr. Gardner or, yep.
Phil Glick from surgery. When third-party payers use AI to make denials or agree to payment of care, why is that or is not that a HIPAA violation? They must have to put the patient's confidential medical information into their algorithms so they understand what the issues are.
That's not a HIPAA violation currently. It should be, but it's not a current HIPAA violation currently, predominantly because they are saying that we are using this to develop our own internal products and services, and they are not exposing it to anyone else. It's a limitation, but it's not a violation currently.
Other questions?
Hi, I'm Doug Lanso. I'm Chair of Biostatistics here at Buffalo. My question, since this is talking about health equity, I've done a lot of work with minority serving institutions, and one of the things that I hear from them loud and clear is that a lot of the efforts that go on, research that are labeled as health equity, are still not equitable in terms of where funding goes, how universities are involved, where the voice is coming from in terms of the direction. And I'm curious from either of your perspectives,
Sorry, I didn't catch the last part of the question.
Sorry, what's that?
I didn't catch the later part of the question.
Oh,
Sorry.
I'm just asking if the issue of lack of involvement of the people that should be stakeholders in the process, as a, for instance, if it's a research effort talking about minority or Hispanic serving institutions. And I'm curious whether either of you wanted to comment in terms of whether you agree that's an issue in AI research and whether you see any movement toward improving that or even seeing it worsening.
I can go first, but I think this is Dr. Gardner's area more than mine. I think that that's a major issue right now in the AI field. And that's why we're trying to put together this community advisory board around AI, particularly for things that affect them. I think that ultimately it has to be at the regulation and policy level where people get transparency and a voice in things that affect their health or broad, their own health, but also the community health and largely how healthcare decisions get made. I mean, some of you might agree and some of you might not. We were on a trajectory to do that, but like the current political climate is not necessarily very conducive towards doing that. But hopefully things will change. But healthcare systems actually, if you have enough voices from within, and ultimately it turns out to be much better for everyone because these algorithms again are less biased, get adopted more. Communities feel a sense of trust. So it's a win-win for all, in my opinion.
Well, thank you so much for joining us today. It was a pleasure talking with you. And I think this is such a critically important topic. We need to continue this conversation about how to make sure that bias does not creep into the way we care for folks, with AI being the tool through which care is delivered. I said that very convolutedly. I apologize.
Thank you so much. It was an honor and a pleasure. Really appreciate you. And thank you for having me.
Thank you so much.
Thanks again, Dr. Ned Carney.
Thank you.
Next time, hopefully we are able to bring you back to Buffalo again.
I would love to. I love Buffalo.
And we keep tapping into you on so many topics. Maybe we just need to bring you to UB. So, all right. Thanks again. Good to see you.
Thank you.
Thank you, Dr. Gardner, for leading the conversation. Everybody was very enthusiastic about covering this as part of the session today, and you were perfect. So, the last part of our session today is actually, I'm going to take probably 5 minutes of your time for those of you that are still online and also here. And I just want to highlight a few things about the office that I'm situated in that can help potentially, as Dr. Noyes smartly pointed out, maybe get new projects started or look for resources that could enhance some of the work that you're doing in this space. So if you bear with me for 1 minute. There we go. My name is Jill Cizek, and as I mentioned earlier this morning, when we first opened the day, I work for Dr. Bashir in the Office of the Vice President for Health Sciences. So today was coordinated by our colleagues in the Office of the Vice President for Health Sciences because we very much recognize that bringing people together across all of the health science schools and obviously our colleagues on North Campus in engineering and College of Arts and Sciences is really critical to moving big conversations and big projects and answering large-scale questions better because interdisciplinary teams really come up with more impactful solutions. So the office that I'm situated in, we do a number of different things in addition to programming, and I want to highlight one aspect of it. We support investigators who are pursuing any sort of large-scale or complex research funding opportunities. Investigators who come to us typically would be pursuing a PCORI submission. Dr. Noyes, we just supported her in this past fall. We would work with investigators who are going after training grants, NIHP awards, anything that is a little bit more large scale that at the department level would be more challenging for the administrative teams within the units to take on as far as preparation, because so much goes into some of the more complex mechanisms. And so our team is here to help support that. One of the things that we do find is critical, though, is actually prospecting for funding opportunities. Everybody knows there are lots of resources that are out there, databases that exist, query mechanisms. The university purchases subscriptions to a number of different tools that can find you funding opportunities. And from an administrative perspective, one of the things that I don't think is highest and best used of faculty time is to try and have to go out there and scrub all of those resources on their own. So I'm introducing you. We actually just launched this back in December. Daniel Fecchiotti joined our team. He's a graduate student in the School of Public Health and Health Professions. He's extremely talented. He not only understands the health sciences space, but he actually has a great data science background as well. And so he's with us half-time. For anybody that would like to schedule an appointment, the QR code right up there will actually direct you right to his calendar. And what he is doing right now is he's scheduling with investigators or teams or labs, and he will sit down and speak with you about the project that you want to get started, what research your group is doing, what area you might want to explore more. And then he will go out and tap into all of the tools that we have here on campus and that we take advantage of both on campus and nationally, and look for funding opportunities that fit. And he's providing reports back to faculty as far as upcoming opportunities, things that are on the horizon. And he's looking at a lot of different sources. So he's not just going to the NIH sites. He's looking into foundation and organization funding opportunities. He's also just scrubbing in a lot of different directions. So I would encourage any of you, if you are out there and you're wanting to start a new project, like Dr. Noyes was mentioning, as far as even seed funding, to connect with him. He's extremely thorough, and then he'll provide you a detailed explanation back with all of the opportunities that he finds. In addition to that, we've set up, I know, who wants more email? It's the nature of the beast, I think. We've set up a prospecting listserv. If you scan this QR code, it will send an email to my colleague, Karen Ventrilla, who was sitting at the table welcoming everybody here today. We find that a lot of times an organization will reach out to us. The VPR's office finds out about a funding opportunity. The corporate and foundations office has something that comes across their desk that isn't on a regular schedule from a foundation or an organization. The last thing that we want to do is spam faculty and staff across all of the health science schools. So we've actually created a listserv that you can opt into so that when the funding opportunities come up in a timely fashion, we're pushing out to those people. So I would encourage any of you to drop Karen an email. And of course, at a certain point, you can opt out. But I think we're probably seeing a level of frequency of like 1 or 2 funding opportunities that we come across per week. It's nothing significant or overwhelming. And then lastly, just wanted to say thank you for attending. The QR code that is on the screen in front of you right now will take you to a Google document. We value the feedback for the sessions that we put on because it helps us go into next fiscal year or next academic year and figure out what are the topics that were that resonated with you most, What are the topics that you would like to see us aim towards for future programming? So if you have a minute to just take the quick survey, it's anonymous and I think it's very, very basic and 4 simple questions. So I would encourage you to do that. But otherwise, my office is here, and we're so thankful to all of the presenters who came today. We're thankful to all of you who wanted to be here in person and that you actually came. Goodness gracious, we need to look at how this registration stuff works. I mean, 140 people register, and we know that there's attrition, but it does get a little bit frustrating at times. So thanks to each of you for taking the time to actually come down and stay with us, and those of you that joined us online. We do record all of our sessions, whether it's the 1-hour sessions that we do at lunchtime or a day like today. All of the recordings for the different elements of the day will be on our Health Sciences YouTube channel. Dr. Adler-Milstein said that we could actually also share her slides. So we will put those out there as well. And yep, you have a question? Oh, really? Okay. Yes, I actually, it's in the chat, but I'll put it up there right now. Sure, we can do that. That's fine. Let me see if I can pull the chat up. Yeah, we'll do that because otherwise you're not going to be retyping all of that into your systems right now. So yes, we'll send the hyperlink out for the survey. So thanks to each of you for coming. Please feel to reach out if you have any questions, especially if you are interested in finding some funding opportunities in these areas. And thanks for joining us today. There is lunch on the table outside. It's boxed lunches, so please feel free to take one with you. If you're going back to an office and you have a colleague who's there, please take one for them too. We have more than enough. So thank you again.